All right, everyone, welcome back to another edition of the GWJDD Dermatology Translational Science Lecture Series. I'd first like to thank Genentech for providing us general support to bring us our speaker today, Dr. David Polsky. Dr. Polsky is Professor of Dermatology and Pathology and is also the Alfred Kopf Professor of Dermatologic Oncology at NYU in Manhattan, New York. He also serves as the director of the Pigment and Lesion Clinic, so we're getting a theme here. But I do want to note he was the program director for 9 years. So I guess there's a light at the end of the tunnel afterwards. Good to know. His research interests are both clinical and translational, focusing on identifying biomarkers to better identify both atypical nevi and melanoma, as well as creating risk stratification indices for really getting a better understanding of how to manage these patients. He has an NIH-funded lab, and I think has been funded by almost every derm society there is, has close to 100 publications, and he lectures so extensively that on his NYU CV, he had to write too many to list. So I think we're in for a real treat. And I also want to highlight he is a fellow alum from Einstein, so I knew there was a connection there. So please help me welcome Dr. David Polsky.
Great, okay. Thanks so much for that intro. Let me just get oriented here at this point. Terrific. I was really thrilled to get an invitation to talk about my research. Often just asked to talk about clinical things, so we can just get right into it. Just some disclosures. Molecular MD Corporation is a molecular diagnostics company. I serve as a consultant, and they do provide the lab with some in-kind research support. Biorad Corporation also makes equipment and reagents, and we have a very fruitful collaboration with them, and they are helping us with in-kind support. And I've served on advisory boards for Novartis, so very nice that they're helping to support this. Okay, so when I think about translational research, I think about really it's clinical research, but using tools of molecular biology and bringing them to the clinic, or taking clinical observations and then going back to the lab to try and figure out what's going on. So that's kind of sort of the theme here. We said these were really interesting grand rounds cases. Thank you, guys. You know, I do pigmented lesions, so I like to show this example. You know, this is a melanoma, and there's a nevus here. And you look and you say, gee, there's this darkly pigmented papule here and this red papule here. You know, and it's interesting visually, it's interesting clinically. It's also interesting from a biological standpoint, what's going on in these cells that's caused this transformation, and why are these two different from each other? And as dermatologists, we get to observe this kind of stuff every day, even the stuff that we saw today in grand rounds. You know, you look at the path, you say, well, you know, when I was a resident, I would look at the path of melanocytic things, and they were always these sun-damaged melanocytes, and the pathologist could never tell us, well, are they really melanoma cells, or are they just sun-damaged melanocytes? And I was like, well, gee, that would be an interesting question to figure out, which I haven't actually tried to figure out. But I don't know if anybody's got a clue yet there. But anyway, more of clinical importance, of course, is what takes, you know, cells here and allows them to escape the skin. Even when these lesions are really small, you know, melanoma is staged based on millimeters. Other cancers are staged based on centimeters. So why is it so highly lethal? Why can these cells escape the skin, go elsewhere, shown here as skin mets, but more seriously as brain, liver, lung mets, most common sites for melanoma metastases. So it's just a reminder that here's a primary melanoma here on the leg. 5-year survival when caught early, very high, about 98%. But common sites of metastases are the lymph nodes. All comers for lymph node metastases, stage 3 is about 63% survival, with a very, very wide range for micrometastatic disease in the lymph node versus bulky nodal disease. And then distant sites that I mentioned before. Historically, survival was maybe 15% at best, but now with the new therapies, really up to about 30% 5-year survival. But still, we obviously have a long way to go. So another way to think about this and how we see things in the clinic is just to look at the full spectrum of the disease. So melanoma has a clear environmental link with ultraviolet light damage. Probably there are patients who are genetically predisposed because you can see that ultimately a lot of people get a lot of sun exposure, but really relatively only few get melanoma. We know that ultraviolet light contributes to the formation of moles, which of course are benign. And then of course there's melanoma, which can occur as well. And we know that there's sort of two ways to get to melanoma, at least I suppose, but just generally speaking, you can either have what we call de novo melanoma or melanoma arising in association with nevi, and there's some data definitely suggesting that there's a link here. But I'm going to ask a question. What do you think the percentages are here? So is this like 50-50, 90-10, 25-75? Anybody want to make a guess?
Depends on who you read.
Depends on who you read. Okay. So I don't have the
85-15%.
Which way? Which one is 85?
De novo, 15% from nevi.
Okay, great.
Bernie Ackerman's at 90-10 because of African Americans.
Okay, well, okay. So the incidence of melanoma in African Americans is about tenfold less than Caucasians. So pretty much I'm focused on melanoma among Caucasians, although we do have some cases that we see at our center. Anyway, that's really close. So and you say it does vary in studies, but really it's about 75%. I'm not talking about it in detail here, but we published a large study in the Journal of National Cancer Institute last year, two very large prospective databases from our institution. Separated by 30 years and over 1,000 patients. And when we looked at this, among other things, we saw that about 75% of the time melanomas are de novo. So there's a lot of fuss about moles turning into melanoma, but most of the time these occur just from normal skin. Okay, so of course we treat primary melanoma. Some patients are cured surgically, others go on to metastases. Again, we can treat them and some survive. Now, understanding what's going on here, okay, this is what we call molecular pathogenesis. This is really, part of the translational research is what's the biology, driving this, and then, these are clinical observations. What do they suggest to us to frame questions for PhD researchers who really don't understand the clinical side? They need us to inform them, what's the right question to ask? They're really good at answering questions, designing experiments, but what's really the most impactful question that they can ask, and having clinical relevance is so important. So down on the other side is, okay, here as clinicians, what can we do? Well, risk assessment, trying to understand, well, who's really at risk for developing primary melanoma, and what can we do in terms of primary prevention? Not too much at the moment, other than perhaps sun exposure. Then there's secondary prevention, right? So that's really early detection. That's what secondary prevention is. We're preventing metastases. So here it's early detection. So it's everything that we do to try and recognize melanomas early and cut them out when they can be cured surgically. And then later on, well, we can look at prognosis. You can look at a primary melanoma. We know about tumor staging. I'm not going to go into that, but that's basically based on prognosis. Tumor thickness is a major driver. Whether a patient has a positive sentinel node, also even a more important driver, a determinant, I should say, of outcome. And then how do we monitor disease in the metastatic setting? So I've worked kind of along the spectrum here in my career. Right now we're sort of focused on two ends, risk assessment over here, and then disease monitoring over here, and that's what I'm going to talk about. So I'm talking about risk assessment. So, well, one question is, well, why bother assessing risk for melanoma? So you might say, okay, well, if I identify people at high risk for melanoma, we might be able to reduce morbidity or mortality by having them come in for screening exams, catch melanomas early, smaller surgeries, less sentinel node biopsies that need to be done. So we can reduce morbidity and mortality, and also messaging. Okay, if you say, look, you really have a chance of getting melanoma. You're fair-skinned. You've got red hair. You've had lots of sunburns. We really ought to come in more often, maybe twice a year instead of once a year, or even just get them in the door once a year. If you explain to them sort of why, you might have more impact. But of course, you have to be careful if you go down that route. You can't just tell somebody who's low risk that they have no risk, although that might be what they end up interpreting. But this is an area to investigate. Now, some people might say, well, why bother figuring out who's at high risk? Just screen everybody, right? Because we don't really know who's at high risk yet. So this was done. I don't know how many of you know this study done in Germany. Basically, they did population-based screening. So they just said, we're going to screen everybody. They didn't end up actually screening everybody, but they screened, I think it was about 20-some-odd% of them. And here's how this diagram works. This is Schleswig-Holstein, which is a province in Germany. This is Denmark and a couple of other provinces. And between 1998 and 2000, the mortality from melanoma was about 1.7 per I think it was per million. And then they said, okay, between 1998 and about 2008, we're going to do an educational campaign. We're going to raise awareness about melanoma in the community. We're going to train doctors to do skin exams, and we're going to pay people to do skin exams of, I don't know, 30 euros or whatever. It wasn't a lot, but they were basically, incentivizing people to do skin exams. And then at the halfway point, they said, okay, let's implement this program, and then let's look at the mortality 5 years later. So they were kind of building up to it, and the halfway point, they started doing the screenings. And then they looked at the mortality 10 years later. So you can hear Schleswig-Holstein, the color is lighter because the mortality was cut by about half. So wow, this is great. And they didn't do any of this stuff in the surrounding areas or in Denmark, so their mortality was unchanged. So they didn't have a real control group, but this was kind of pretty close to a control group. And they said, boy, we can reduce mortality by 50%, but it costs a lot. The number needed to screen was 127,000 people. Okay, now I won't go into the math of how you calculate that, but basically this was how it worked out. You needed to screen 143,000 women, 111,000 men to save one life from melanoma. Right? I say, oh, that sounds like a lot. What about other cancers? Well, colon cancer is like the poster child for screening, right? I mean, there's no reason why people should die from colon cancer. Go get colonoscopy, catch it early, and you only need to screen 100 people roughly to save a life from colon cancer. I mean, this is really, a real success story. And if you look at colon cancer mortality, it's really been going down. Here's the story in breast cancer. You got to screen a lot more women, okay? And you can see part of the controversy of you should just start screening at 40 or 50 or 60 is because you need to screen a lot of people who are younger because the disease is less common. So that's kind of what we're running into with melanoma. The disease is not that common, and also when caught early, people don't die from it. So anyway, these are the numbers for breast cancer. So, you're talking about hundreds of people, and in prostate cancer, I don't know if you can see it, but it's like 1,000 people, right? So we're up here at like 100,000 people. So, you got to be kidding me. Nobody's ever going to pay for that, right? So, but the Germans said, okay, this is good. They decided we're going to do this. So they did it countrywide, but they said, let's just do the screen. Let's just tell everybody to get a skin exam, but we're not going to pay the doctors to do it, and we can't invest in all that educational stuff. Let's just look at the outcome when we just tell people to go and do it. And of course, it didn't work. The follow-up study, there was no decrease in mortality at all. So the education is a really key part of it, and incentivizing people to actually do the screening. So is there a better way? Well, maybe if we identify these high-risk people, we'll decrease the number needed to screen, right, to save a life. So what can we do now? So we do what we always do. We can do a history and physical, and these are melanoma risk factors. I'm sure you're familiar. If a patient had a prior melanoma, light bulb should go off. They've got some potentially genetic predisposition to get this. The risk of a second primary melanoma is about 8 to 10-fold higher in those patients. Family history we'll talk about in just a moment. UV exposure, indoor tanning is probably worse than outdoor sun exposure, especially when you get to higher levels of exposure, and some other risk factors here of lesser importance. And physical examination, okay, people's mold pattern, we'll talk about a bit, and the other factors that you're very familiar with. Okay, but stop for a quick resident question. Which individuals are at the greatest risk for melanoma? Somebody throw something out? Anything? People with a family history, people with a lot of moles, some rare disease. I'm thinking rare disease. XP. XP. I mean, they are. They're at the highest risk, right? But the interesting thing about people with XP, so they have 1,000-fold increased risk of melanoma. It's an autosomal recessive disorder, and they have genetic variants in DNA repair. So, right, I'm a lab rat, really. And I look at it and say, wow, this is an experiment right here, okay? So we know that if you screw up DNA repair, you have this huge increase in getting melanoma. So probably DNA repair is important to prevent melanoma in people, and maybe if we can identify just, sort of lower functioning variants in DNA repair genes, maybe those are some of the genes we're looking for. Hasn't quite borne out enough yet. I think we don't really understand enough about the process and perhaps the inheritance, but I think that this is really a clue as to why people get melanoma. Okay, so now people get away from XP. What about people you might see in the clinic more commonly? So the patient comes in with a family history. So if they come in and they say, like, I've got 3 first or second degree relatives who had melanoma, and maybe one died from melanoma, they sound like they're pretty educated. Certainly one patient died from melanoma. You're not mischaracterizing that. Those sound like a real family history. But it turns out that 40% of family histories might actually be inaccurate. So the patient situation I just described, that sounds pretty accurate, and that number of affected, that's pretty substantial. But the patient says, oh, my uncle had a melanoma, okay, that's 1 second degree relative, not such a strong factor. I kind of use that though to motivate the patient to come in and get a skin check, but how much of a risk they have, not exactly sure. But I don't think I've ever sent anybody for genetic counseling. Even in these loaded families, which I don't see all that often, but I don't think it changes our management. Whether you know that they have CDKN2A or not, I'm still managing them as a high-risk patient. But if you choose to do this, I think you really should do it with a genetic counselor. You shouldn't do it on your own. And about 90% of melanoma patients lack a family history, and those are patients I'm most interested in to try and figure out how to identify the high-risk patients. So what can we do to kind of more rigorously figure this out? We can develop what we call risk models and risk scores. So you may know all of this already, but basically to develop a risk model, you identify these statistically significant risk factors, and some of which I showed you before. You combine them into an equation. I'm terrible at math, so we won't go into that. And then you assess the ability of the model to correctly classify cases and controls, and you plot this, what we call a receiver operating characteristic curve. So this is the sensitivity of your test to detect the truly positive. The specificity of your test is plotted here. This is 1 minus specificity, so 100% specificity really ends up over here. So the best possible test is up in the left-hand corner. It's got maximum sensitivity, maximum specificity. And after you plot that, you make that equation, you plot this curve. Your predictive ability is measured by the area under this curve here. That's called the AUC. And any test that you order is going to be a trade-off between sensitivity and specificity. So back in 2014, there was a paper reviewing published risk models as of 2013. People have done a lot of this. There were 28 models identified. You round up the usual suspects in terms of risk factors. And depending on the population that was studied and the coefficients that they derived, for the weighting factors for these equations, the AUC ranged from 0.62 to 0.86 for the 9 models. It's thought that once you get above 0.8, you're really getting to where it could be clinically useful. But none of them were replicated. I think maybe one was replicated in a very small second set. More recently, this was a meta-analysis published in 2015. They looked at 16 case control studies. They pooled the odds ratios to assign these weighting factors here, and they came up with a score that you could technically calculate when you see the patient in clinic. And a score ranged from 1 to 233, and they had these different categories here. Low risk was less than 3, medium to low 3 to 8, medium high 8 to 32, and very high more than 32, 33. And here are the risk factors here. But I just want to show we talk about the risk factors. How important is hair color versus their skin phototype versus their freckle? These are really small odds ratios, right? They're like 1.5, not even 2. Family history of melanoma 1.74. That's because most of the time it's not accurate, right? So you got a mixture of accurate and inaccurate, which I think drives this down. But what is reproducibly important is total body nevus count. You can see here sort of a dose response. The higher the nevus, if you're in like the 90th percentile, your odds ratio is 5.5. That's the highest one on the chart. And the number of large nevi that you have. So if you have more than 3 nevi, more than or equal to 5 millimeters, your odds ratio is 4. And sunburn's not very good, 1.3. Right? So we ask about these things, and we spend a lot of time talking about sun protection, but the truth is, it's not a very strong risk factor. So anyway, that's the sort of the lowdown on risk factors. I tend to focus on nevi. That's a lot of the patients I see, but also biologically, I'm thinking, okay, if you can make a lot of moles, something's up there where you can easily have your melanocytes, tipped over to become a melanoma. So, okay, so here's a sample patient. Patient comes into your office, they want a skin check, and they want to know about their melanoma risk. They've got red hair, skin type 1, they've got fairly extensive freckling, they don't have any large nevi, hardly have any moles. They said, no, I never had a severe sunburn, and nobody in my family had melanoma. So where do you think they would fall in this category? How many people say that this is a low-risk patient? 1, 2, okay. How many say medium to low risk? We got a bit more. Medium to high risk? No? I guess anybody high risk? No. Most people aren't sure. Okay, so that's fine. Risk score is 4.62, so it's a medium to low risk patient. Okay, so you say, okay, well now, all right, what do I do with that number? What does that actually mean? What should I tell the patient? Well, here's the ROC curve from that they validated in an independent set. So that was one of the strengths of the study. They derived all this from multiple reviews, and then they said, let me take an independent data set and see how well does it classify melanoma patients from controls, and their AUC was 0.75, so not quite at that magic 0.8, but pretty close. But it turns out in the medium to low, so that was 22% of melanoma cases, right? So 1 out of 5 melanoma cases would fall into that category of that patient. But if you look overall, 29% of cases were high risk, but 58% of cases were medium risk. So and 13% of cases fell into that low risk. So if you say, well, where am I going to stratify to say, well, should you come in once a year for skin check, twice a year for skin check? It's unclear to me, where you draw the line, because if you draw the line here, say, oh, I'm going to bring in these people, you're going to miss 70% of the cases. So we need to do better. So like I said, I focus on nevi. This was from a study that we collaborated on. It was the Minnesota Skin Health Study. Some may know about it from several years ago. One of the key studies that associated indoor tanning and melanoma, because they were able to estimate like a dose-response relationship. So this is just looking at nevi, and the patients were divided up into 4 categories. So they have no nevi, some nevi, a few nevi here, 1 to 25, some and many, and the patients checked off where they would categorize themselves here. And if you look, you can see this is how these odds ratios are derived. People with the many nevi, we know these have high risk. The odds ratio was 14-fold increased risk, and it's a dose response, as you can see. So if you say, okay, well, the people in this group, the top 2 groups, that represents 28% of the cases. We call these patients nevus prone, but 72% of the melanoma cases, okay, were in this kind of not very moly group. Okay, those have been called nevus resistant. So what I'd like to know is, how do I take the patient who comes into the office who doesn't look high risk and figure out who among them is really going to be the people at high risk to put into some kind of screening program, perhaps. And I think that's our really big challenge. We know what to do with these patients. These patients come in, say, oh, you're going to maybe get total body photos, or you got to come in frequently. These are the ones that we can identify just from the clinical exam. Okay, so right, so most melanoma patients don't have an increased number of moles. This was, again, a population-based study, so a little less biased than, say, a hospital cohort. So before you give me the money to do this, right, Alan's in the back there, used to be running the NIH Institute there for skin disease. Before he's going to give us the money, how do we know that if we have one of these things, that it'll actually work? You say, well, here's an interesting study. This was from France. They came up with a self-assessment risk score, and it was a collaborative project between GPs and dermatologists. They looked at about 8,000 consecutive patients in the summer, June to October. They had a 7-question risk factor, seven-question risk factor questionnaire. And when they filled that out, about 30% of the patients were considered high risk. You say, oh, that sort of sounds like some of the numbers we've been throwing out. And they said, okay, if they were high risk, they had a full body screening by the GP, and 1,000 of them, and they were referred. I think all of them were referred to the dermatologist, but only 1,000 of them went to the dermatologist. There were 95 biopsies done, and there were 10 melanomas found, and 21 non-melanoma skin cancers, keratinocyte carcinomas. So this was calculated to be an 11-fold enrichment in melanoma detection by sort of taking this high-risk group. So that sounds like a success story, but the problem was we don't know about the sort of the false negative. So how many patients who were not high risk got melanoma. We don't have those data. And there was also, most of the patients who were considered high risk never actually went to the dermatologist, so we don't know how many of those actually had melanoma or not. So definitely big challenges in this kind of research, but I think it's kind of promising that, you know, maybe we can make progress, and obviously a lot of behavioral research needs to go into this as well to try and figure out how to get people to be checked out even if they're identified as high risk. So how can we improve things? Well, it's kind of like a pie. I told you about moles, pigmentation, you know, not such strong risk factor, lower odds ratios, indoor and outdoor UV. So the missing piece of the pie, I think, is, and other things, is genetics. We looked first at the melanocortin receptor gene. So you may know that the melanocortin receptor basically has two functions. Mostly we focus on pigmentation. So this is a beautiful cartoon showing a keratinocyte here, keratinocyte here and a melanocyte here. So the MC1R receptors here on the melanocyte. This shows in response, this is a tanning response. In response to ultraviolet damage on the keratinocyte, there's DNA damage, activation of P53 tumor suppressor, and that leads to secretion of MSH, which binds to the receptor, catalyzing melanogenesis, and then transfer of melanosomes to keratinocytes. You know, these are very altruistic cells here. They're giving off the melanin to protect the keratinocyte, and there's some nice pictures that you can see in pathology with the melanosomes over the nucleus of the keratinocyte as like an umbrella. So that's the pigmentation response, and we know that the kind of variants in the MC1R that are associated with red hair. So there's a constitutive function here as well as a sun response function. But also more recently, it's been shown that activation of MC1R is important in DNA repair. Both in vitro studies of cells and animal studies have found that it's involved in DNA damage repair as well as UV-independent oxidative stress. And we know that the variants in MC1R are associated with melanoma even after adjusting for the red hair phenotype. So if there's any MC1R gurus out there, you know, there's multiple variants. There are these variants that are polymorphism, basically, lower functioning alleles, and are associated with pheomelanin, right? That's the precursor to eumelanin. So if you have these alleles, they're considered called big R because they're really tightly associated with red hair. Their odds ratios, right? These are real odds ratios, right? 50 to 120. If you have that, you have the phenotype, right? Then there's these ones that are less tightly associated, so they have lower odds ratios. Both of them are associated with increased risk. The big R have a stronger association than the little r. So you might say, okay, fine, they're associated with red hair. I don't need to know somebody's MC1R genotype. I just need to know if they have red hair. Well, it turns out that's not the whole story, because this is from that Minnesota skin health study that I told you a little bit about, and I'll tell you a little bit about in a moment. It turns out that if you look at all subjects and just look at hair color, cases and controls, it turns out that if everybody who had brown or black hair, this was their MC1R. Okay, so most of them had the consensus, or maybe one little r or two little r's. But here are people who had one of those big R's that you say they should have red hair, but they actually had dark brown or black hair, right? So these alleles are associated with risk for melanoma, independent of hair color. And now you say, well, okay, some of the people who you're going to see in clinic have dark hair are going to have one of these alleles. So I've gotten into the habit in my resident clinic, when a patient comes in, they've had melanoma and they have dark hair, I ask them if they had anyone in the family had red hair. And oftentimes they say, oh yeah, you know, my sister has red hair, or something like that. So they're probably one of these dark-haired people who is carrying a red hair allele, and maybe that contributed to their melanoma risk. Okay, so we wanted to know how well would MC1R work in one of these risk prediction models where we could draw an AUC curve. So this was this Minnesota Skin Health study. We had 1,640 subjects from the study. We sequenced the MC1R from everybody. They all did buccal swab collection to get DNA. We had detailed demographic information and UV exposure history, and we looked for the associations between the MC1R polymorphism to the ultraviolet light exposure and whether they were melanomas or controls, and we developed these models. So here's what we found. So the blue line, you say, you look and say, gee, that doesn't look like much of anything, right? There's a blue line and a green line is pretty much overlapping with it. But it turns out the clinical risk prediction model that I've been talking about before, we had an AUC here of 0.72. But if we looked at their MC1R genotype and we classified them into big R little r, etc. And we combined it with their indoor tanning exposure. We could see that the AUC went up by 2%. And that was statistically significant. I might say, oh, 2%, that's nothing. 2% is really big in this business because, and for a single gene and an environmental exposure, that's a lot. When you look at breast cancer models, like there's a famous model called the Gale model to try and predict who's going to develop breast cancer, they're barely moving the needle with multiple genes. So we were encouraged by this, that there's some potential here. The interesting thing, and this is kind of getting into the weeds a little bit, was when we broke it down by patients who have lots of moles versus don't have lots of moles, we found something interesting. Remember, I told you that the patients with lots of moles, I kind of know what to do with them, right? You know what to do with them. How did our model work? Well, it turns out when we looked at all comers, we had an AUC of 0.72 for the clinical factors alone. When we said, well, let's just look at these nevus-prone patients. So that means taking the melanoma patients who look like this and the cases without melanoma who look like this. And now you can see the model doesn't do so well because that factor of having lots of moles, which was sort of driving the risk, is you have lots of moles in both groups. So you're now relying on other things, and the model really doesn't do very well. But when you add the genetic factor and the indoor tanning exposure, we have like a 7% increase, which was really striking. If you look at these patients who are the ones that are clinically challenging, right, because they don't have a lot of moles, the clinical model was 0.69, and the genetics added about 3% in the UV exposure. So I think there's something different in these two populations, and as we move forward, we may have to pay attention to this in this work. Okay, so we need more genetic variables, so we're starting to work on that. We may need different variables for the nevus-prone versus the nevus-resistant patients. Also, there's evidence that people with different ancestry groups, these risk factors may play out a little bit differently. So Caucasians can be divided into Northern European, Southern European, and Ashkenazi Jewish as three main subtypes. And there's some data to suggest that some of these alleles have different weighting or different effects in these groups. And obviously, we have to replicate it. So what's the future paradigm? Well, you can have a patient fill out this diagram. And if they're what we call nevus resistant, you might have a risk model, right? You say, okay, all you need to do is spit in a cup now to get the person's genomic DNA. You've heard about 23andMe and Ancestry.com and all that. Same idea, spit in a cup or whatever, and you run it. And you say, okay, well, you're nevus resistant, you're genetically low risk, go see your primary care, tell them what A, B, C, D, E, ugly duckling, something new comes up on your skin, don't wait, go get a skin check, right? But if you're in this group here and you say, gee, you're genetically high risk even though you don't have a lot of moles, say, you know what, maybe you should come once a year, plus we'll give you all this information to pay attention to your skin, because my suspicion is that these are the people who come in sort of later because they're not under regular surveillance. So maybe if we could plug them into more surveillance, we can catch things earlier. And then for the patients who have lots of moles, well, maybe we can do better because, even this group of patients, I think it's only about 10% of them get melanoma if you follow them, for 10 years, at least in one study from our institution years ago. So you could have the nevus-prone patient that's genetically low risk. Yeah, you would want to screen them, but maybe you don't have to have the same degree of surveillance like that you might have in the high risk. These patients may come, 2, maybe 3 times a day. You have total body photos. You might do whatever, right? These patients, you can maybe tone it down a little bit. I think the greatest impact can be in this group here. Okay, any questions before I move on to the second half? Yes?
So, do you think we should really be asking all of our patients, do you have a close family member with red hair, or that some of their hair grows in red? Because there's certainly many people who might have dark hair on their head and grow in a red beard. And if so, do you think we should push this as more of a public health message? Because I don't think the general population understands. They might understand that having red hair potentially increases your risk of melanoma, but I do not think the general population understands that having a close family member who has red hair genetically increases your risk.
Right, so I agree with the idea. Let's get the data. Let's go suss it out so we can really back up the recommendations. Say, based on such and such a study, we think that if you have a close family member with red hair, you have a chance of having that gene that has a significant association with melanoma. And you should check your skin, see your doctor, look out for new or changing lesions. Yeah, I think that I think we should only make these recommendations when we have good data, but I think we'd be able to get the data. I think that's a really good idea. Okay, any other questions about the front end of melanoma? Okay, so now I'm going to move on to disease monitoring. This is what we're focused on mostly in the lab these days. I'm very fortunate at NYU. We have a big melanoma program. Medical oncologists, surgical oncologists for many, many years. It's been very strong. It's gotten even stronger in the time that I've been back as a faculty member. We have a big, we call biorepository program. So when patients come in, basically we consent them to release their tissue for us to collect blood and for us to follow up. I think it's every 6 months roughly, or for patients who have more active stage 4 disease, every 3 months on the clinical follow-up to know their status and if their disease is progressing or not, or just review their charts. So I've been able to take advantage of the resources to work in this area. Just to review, many of you probably know this already, but this pathway, the RAS-RAF-MAP kinase pathway, is a critical driver for melanoma, very important in many cancers, but really critical in melanoma. And basically, you know, the tumor has sort of co-opted a normal cell signaling pathway through mutation to basically make this what I call the stuck gas pedal of cancer, right? So we know that BRAF mutations about 40 to 50% of melanomas, NRAS probably about 20% of melanomas. There are others, obviously I'm not going to get into. This has kind of been the focus of most of our work. These are hotspot mutations, so BRAF, 90% of those mutations are in the V600, which is very helpful for us in the assays that we develop. And in NRAS, about 80% of the mutations are in the Q61 amino acid. Again, these hotspots mean that when we develop assays that I'll tell you about, if we're detecting specific mutations, we don't have to go develop assays for a lot of mutations. Signaling through this pathway is blocked by P16, which is the CDKN2A. That's often inactivated in melanoma. We've done some work in that area. Normal signaling leads to phosphorylation of the retinoblastoma tumor suppressor, and that leads to cell proliferation here. Just, you know, it's been remarkable. The pace of discovery and the ability, I'm trying to remember exactly I think this BRAF mutation was described around 2003, 2004, and it didn't take very long in the big scheme of things to come up with drugs to block it and put into clinical trials based on a lot of first in vitro data, then mouse model data, and then clinical trials to get us where we're at today. I'm sure you've seen these pictures or similar pictures. I particularly like these. These are PET scan pictures. There's a patient has loaded with metastatic melanoma, 2 weeks only of the BRAF inhibitor vemurafenib, and you can see the tumor goes cold. Same thing here in this patient with really, really extensive metastatic disease. I mean, it's really like, you know, an off switch. And these are also very famous pictures of what you might see in the clinic, right? So the patient loaded with skin mets has just about a near complete response, 15 weeks on treatment. The problem, of course, was that resistance develops to single agent therapy, and then only a couple of months later, you know, the disease came roaring back. As people say, we sort of we have a foothold on the disease, but we're nowhere near, you know, really controlling it. This was the Kaplan-Meier curve of the original paper of single agent vemurafenib. This is progression-free survival. Dacarbazine was the standard of care. Vemurafenib, you can see a very long extension, unfortunately only measured in months, okay, but still significant extension. But again, the problem with is that everybody kind of ended up progressing down here, and this was the overall survival benefit, sort of the same kind of story, and also unfortunately measured in months. We know, going back looking at these tumors, why does this happen, right? Well, it turns out that this pathway, this is this proliferation pathway I was just telling you about, BRAF through MEK, ERK down to proliferation, is the tumors figure out another way around it. So you can block that BRAF, okay, with these drugs, but what happens is that the cells that grow out are cells that either have extra copies of BRAF, so it's like, you know, you can't give the patient enough drug to overcome the extra copies of BRAF there. They can mutate RAS, Okay, they can also they can change the splicing of BRAF so that the drug no longer can bind because it's a different isoform. But this just shows you that the tumor requires signaling for this pathway to proliferate, because it's figuring out another way to activate MEK. So fortunately, drug companies came up with MEK inhibitors. And when you combine, here's dabrafenib, this is vemurafenib single agent, this is dabrafenib, another BRAF inhibitor, plus trametinib, which is the MEK inhibitor. You can see now that you've got this extension of from about 7 months to about 12 months of progression-free survival when you combine the BRAF and the MEK therapies. Now the other even more exciting treatments are immune checkpoint blockade, and I say even more exciting because they're working in other cancers. So you may know all this anyway, but I gave a talk recently, and the resident said, "Oh, please tell us about this because just refresh our memory because we may need it for the boards." So you know that there's what's called second signaling, right? This is a T cell that's recognizing a tumor cell. Initially, it was thought the whole business was just the T cell receptor recognizing the antigen on the MHC molecule, but then it was learned that we need to have a second signal to have effective recognition and either killing or release of cytokines, and that tumors figure out a way to shut off the lymphocytes, right? So lymphocytes have to kind of self-regulate themselves, so they put up these molecules that, when activated, turn them off. First drug to target this pathway was CTLA-4, basically to block this interaction, to allow the tumor cell, the T cell to kill the tumor cell. That was ipilimumab. Mind you, we have other antibodies that activate that same molecule, right, that are used in autoimmune diseases. The same CTLA-4, but it activates instead of blocking. But then even more effective, partially because of perhaps the location. These are active in the periphery, whereas this really interaction goes on mostly in lymph nodes. Nivolumab and pembrolizumab block the PD-1, PD-L1 interaction, and these have also been used in Merkel cell carcinoma. So, and you can see here, this is ipilimumab, Kaplan-Meier here. You can see there was some improvement over placebo, which is not shown on this graph. But when you add nivolumab, the PD-1 blocker, you can see an improvement in this is progression-free survival. If you combine Ipi and Nivo, then you get even more improvement, but that's much more toxic. So people are trying to figure out who should get that combo versus the single agent. How can we get rid of toxicity? But the story basically is that that treatment failure, right? All these curves are coming down. Okay, this is actively treated patients. This is patients with adjuvant therapy. So resected metastatic disease. Now you're going to give them one of these agents to prevent recurrence. Ipilimumab does show a small benefit here, but patients actually died on treatment because ipilimumab is toxic. There's new data. Sorry, I didn't include it here, looking at nivolumab versus ipilimumab in the adjuvant setting, and that's really, I think, a breakthrough because nivolumab was significantly better progression-free survival than Ipi and much safer. So that's probably going to be where we go with adjuvant therapy for the moment. But again, still patients are progressing. So we know that if you start patients with on treatment with a lower disease burden, that they do better. So our idea is, well, we've got these agents that we can use. Nobody really knows which one you should give first. Let's say the patient has a BRAF mutation. Should I give them the BRAF MEK, and then when they progress, give them PD-1 or Ipi or both? Or should I give them the immune checkpoint first, and then when they progress, give them the BRAF MEK? Nobody really knows what to do. So there are clinical trials doing, randomizing patients to that to see what goes on. But our idea is that if you could develop a biomarker of early treatment failure, then if you switch the patient really early on, before the disease has kind of really progressed through the therapy, maybe they'll do better. And but unfortunately, in melanoma, we don't have anything. For that, we rely on CAT scans, right? The patient with active disease goes for CAT scans. In these other cancers, we have blood-based markers of varying efficacy, but we don't have anything like that. LDH, by the way, don't ever order an LDH unless the patient's a stage 4 patient, and then let the oncologist do it, right? There's no need to do that in earlier stage disease. It's a really poor marker. So we're really stuck with imaging. So what we got interested in was cell-free circulating tumor DNA. This is a cartoon showing a tumor. Here's a blood vessel. You can have cells escape the tumor, right, go into the blood circulation. We know melanoma can spread that way. Lots of other cancers can spread that way. But it turns out it's really hard to detect these. And in melanoma, it's really hard to detect them because most methods rely on an antibody to capture the cell and then study it. Melanoma, we don't have a good antibody for that. But when the cells die, they release their DNA into the plasma. And technology's gotten to the point where you can easily purify DNA free in the plasma from patients. And we know that patients who have cancer have more DNA in the plasma than normal patients. And with assays that are designed for specific mutations, you can actually calculate, you can quantify how much BRAF mutant DNA is in the plasma of the patient. We use a method called droplet digital PCR, which is from Bio-Rad. You basically extract the DNA here, and you do a PCR reaction, which is just a chemical reaction in a tube. But the magic is that you divide that reaction up into these droplets, and then you can you put them in the thermocycler, and you have probes that detect the mutation or detect the wild type, and then you run it in what's equivalent of a flow cytometer type of setting, and you get a plot that looks like this. So, so these are all individual droplets that have the probe for the mutant, and if they only have that DNA in the droplet, they end up in this upper left-hand corner. If they have only the wild type DNA, they end up in the lower right-hand corner. If they happen to have two copies, one of each, they end up in the middle. So you can see here that you can really clearly separate these groups of droplets, and then because they're you just count them. So when I explain to lay people about why this is better, I said, well, the analogy is the smoothie versus the fruit salad. So the old way, which is just a regular real-time PCR, here's your reaction mixture, right? You put all your reagents in there. And I say, I want to know how blue is my smoothie, right? So I say, okay, let me take some of this, I'll put it in my machine, and I'll figure out how blue is it, right? And you can imagine that if you could instead say, all right, I'm not going to make a smoothie, I'm just going to put these on a conveyor belt and analyze them one by one. If there's only 3 blueberries, right, in my smoothie, I'll know because in my fruit salad, I'll know because I'll see them. So I can detect rare events, and I can count. I can give you an exact count, and that's what's really nice about digital PCR. So it's much more accurate, much more precise. So we did a study of patients with stage 4 melanoma who were undergoing treatment. Their tumor was resected from usually a metastatic tumor, and then what we call the personalized blood test based on the mutation. We basically had assays for 5 mutations. There's 2 BRAF and 3 NRAS. And then we measured their tumor DNA in the blood, and then we compared it to the gold standard, which is really the CT scan and the LDH. And this was what we did. Right, and here's the CT scan showing typically a response that I showed you before. You don't have to read the slides, a lot on it. Basically, we ended up with 22 patients with BRAF mutations and 9 patients with NRAS mutations after screening initially 43. So 31 patients, we had 146 blood samples. This is an example. This is from a tumor, so we have lots of DNA. So you can see lots of droplets positive for, this is a V600K BRAF mutation. Same patient in the blood. Patient had a lot of DNA in their blood. This is a very, very strong response. We don't usually see quite this much. But you can see very easily detectable V600K in the blood of this patient. So what we found was that this blood test that we developed was more sensitive than LDH in detecting the presence of metastatic disease when the patients were starting therapy. So this is a little bit hard to read, I'm sorry. This is before they started therapy, a measure of their disease burden by radiographic, what we call RECIST score. So they add up the diameters of the lesions on the CT scan. They take 5 lesions. They add them up. And what we liked about this was that even in patients who didn't have a lot of disease, less than 5 centimeters of disease, we could still find their ctDNA was elevated 71% of the time. Overall, 80% of the time for all comers. The LDH measurements are only positive 30% of the time. So here's a patient about to start systemic therapy with the oncologist. Their LDH was only elevated 30% of the time. They were starting therapy because of their CT scan, but just shows you how poor this marker is of detecting that. And in those patients with low levels of disease, only 8% were positive. And then when we looked at disease progression, similar story, we found that 82% of the time the DNA test was elevated compared to LDH was only elevated 40% of the time. And in particular, in patients who progressed in the brain, we found elevations 83% of the time, and the LDH was only elevated 50% of the time. Okay, that's a lot of numbers, but this is, I think, an interesting example. So here's kind of how it looked. This is a patient. Here's time on the x-axis. They started with a BRAF MEK first, and then at disease they were added. They basically went to add ipilimumab. You know, this was many years ago. And our oncologist, you know, sort of trying heroically to whatever would work for the patient. So the patient came in. They had a RECIST score of 10.8, which is 10 centimeters of disease. Their DNA, we calculated about 2,000 copies per ml. I didn't mention that when you look at normals, the level is 1 for BRAF and 3 for NRAS. We looked at about 30 normals to get those levels set up. Patient had a really good response. They actually went down to 0 detectable BRAF in their blood after about a month or so. And you can see radiographically they were doing really well. They had a partial response. They went from about 10.8 to 5.9 here. The LDH, this is the normal level, and this is kind of when the oncologist starts to get worried. This is divided by 100 just to scale it properly. But you can see the LDH really didn't do anything much at all during the entire course. The patient, you can see, progressed radiographically and passed, unfortunately, here. The important thing we think here is that the DNA started to go up from 0 to 28 by day 90, and then 900, okay, over here by day 120, and then all the way up to 2900 much later. So what we're thinking is that instead of waiting for this radiographic progression to switch therapy, what if you switch therapy sort of over here? Maybe the patient will do better. We have to do the trial to see, but the trial that we designed, we submitted, part of a SPORE project that's getting reviewed like this weekend, was to randomize patients to monitoring with CT scan versus ctDNA. So we'll see if we ever get to do this trial, but we think that there's potential. And the reason we think there's potential is this is a study from Australia, just looking at survival of patients initiating therapy and looking at variables to predict outcome. And if you look at their ctDNA in the patients who got BRAF MEK therapy and they had less than 10 copies per mil, they had a much better survival than the patients who had more than 10 copies per mil. And the same thing with immune checkpoint blockade. Small study, needs to be replicated, but in a multivariate model, had a hazard ratio of about 6 here, whereas age, sex, LDH, and tumor stage were not significant. So we think there's promise in this approach. The other thing you can do is look for mutations. So another study from the same group. This is showing that initially following, BRAF levels here came down, but when the patient started to develop resistance, they could see NRAS mutations coming up. So as I showed you on that cartoon, one of the ways to become resistant is to develop an NRAS mutation. Turns out you probably want to take the patient off BRAF therapy at that time because it may accelerate the growth of NRAS mutant tumors. So just to wrap up, we think that the droplet digital PCR assays can measure clinically meaningful changes in the plasma levels of these mutations in the cell-free DNA. These values have a very high dynamic range, I didn't point that out before, but much higher than the LDH, and they respond more quickly to changes in the disease status. So we're hopeful that these can become predictive markers of response to both MAP kinase-directed therapies and the immune-based therapies. I skipped my. Oh, okay. Yes. So anyway, so I've sort of taken you on a tour of what I do, what I think about. I hope it's given you some insights, into melanoma. And again, as dermatologists, when you see something in the skin, think about the biology, think about what we can learn, how we can help improve, telling patients what the outcome's likely to be, and how we can improve therapy. So a lot of people are responsible for helping me get this far. We have this large cooperative group here led by my colleague Iman Osman and our clinician statisticians. Lots of support from foundations and NIH and others along the way from University of Minnesota, Deanne Lazovich, Marianne Berwick also helped with this study, my collaborators at Biorad, and some people in the lab. So I'll stop here, take questions. Thank you for listening. Yeah.
Okay. Can you detect the DNA in people, so not in the metastatic patients, but people, let's say, that have a thicker tumor, they're going to get a sentinel lymph node biopsy, that's negative, but could you detect DNA in that situation and then risk stratify?
So we're just working on that right now. We do have preliminary data. We looked at patients with thick primary melanomas who were going for a sentinel node, and it's promising. Definitely, we can detect it in some of those patients. The more disease burden, the more likely we are to detect it. The thing that was interesting to us was whether we could detect it post-operatively. So patient has their tumor resected, has their sentinel node removed, or maybe they've had a lymphadenectomy. They may have disease elsewhere, and the question is, can we detect that at the time of surgery? And we've been able to do it in a few patients, very small. I think we have less than 10 patients so far. I don't remember all the numbers, but it was enough for us to say we should do more of this. So now we're having a more directed collection to try and make sure we catch like everybody who's coming through, and hopefully have some data in the spring.
Was it a lot of copies in those patients?
No, it's typically not the thousands. It's more in 10 to 100.
Less than 100.
Yeah.
Talking to Mike Atkins, who's the head of the Melanoma Center at Lombardi, who's an oncologist, their feeling now is and maybe because of durability of results, that immunotherapy should be used as early as possible, as opposed to the old paradigm where you use the BRAF MEK inhibitors, get the tumor burden down as low as you can, and hit it with immunotherapy at that point when there's less tumor burden to work against. That sort of, since your monitoring is for the BRAF MEK DNA, wouldn't be as valuable in that situation.
No, that's exactly the situation we're talking about. So even in the immunotherapy patients, the response rate is 30, maybe 40%. So there's still, most patients are going to progress through their immunotherapy. It's definitely not the cure. So that's actually the design of our study, which is begin with PD-1 blocker, because more people will go on that versus the combo of the IPI-PD-1, and monitor those patients and randomize them to switching when we see a rise in their ctDNA, which we're going to establish the parameters with an earlier study, versus just wait for it on the CT scan. Mike is actually the PI of that study, I think, the ECOG study of start immuno, switch to BRAF MEK versus start BRAF MEK, switch to immuno, right? I mean, they designed that study a couple of years ago, but I think he's the PI on that. So, but they're waiting for clinical progression to switch. Our idea is to try and switch earlier and see what happens.
And speaking to him, he's also a little bit unhappy that they got locked in with a ratio of IPI to
the old dosing.
The old dosing.
Yeah,
where
which is
there's too much
toxic.
IPI and too much toxicity.
Right, yeah.
So a common bullet point you see, especially in the media, is that one blistering sunburn doubles your lifetime risk of melanoma. But based on your modeling at 1.46, it really wasn't such a high risk factor. So is that kind of misleading?
Yes.
Okay.
I guess I'm on the record. There is a study from University of Pennsylvania. Peggy Tucker, Alan Halpern were on this many years, 1997. I remember specifically because I was a fellow at the time, and they did this case control study of dysplastic nevi, and they made the statement that if you have one clinically dysplastic nevus, you doubled your risk for melanoma. Now, doubling your risk for melanoma sounds serious, right? But I always tell patients in clinic who've had a melanoma, this is like the favorite thing I like to do. I say, okay, you've had one melanoma, so your chance of getting another one's like 8 to 10-fold higher. But these risk factors are relative risk factors. It's kind of like lottery tickets, right? So if you buy 1 ticket or 10 tickets, you're still not winning the lottery, right? Because winning the lottery is really rare. Getting melanoma is still ultimately pretty rare. So if your risk factor is 10-fold higher for getting another melanoma, yeah, that's important for us to pay attention to. But if you look at a population-based study, something like 95% of melanoma patients only have one melanoma in their lifetime. So that's like the balancing thing that I tell patients, like, okay, you have a higher chance of this happening, but odds are it's still not going to happen. So if you can kind of keep those two ideas in your head, show up for clinic, so we don't miss it if it happens, but chances are you're going to be fine. So
And that goes back to the number needed to treat.
exactly, right.